type 2 diabetes or type 1 diabetes, both of them are very important in nephrology practice. As the previous speakers also stated that these people are at risk of developing the metabolic complications and coronary artery disease as well as the chronic kidney disease. And 50% of the patients with the type 2 diabetes and almost nearly 30% of the patients with the type 1 diabetes, they develop kidney disease. But is it the same? And in fact, this particular topic, when it is given to me, I really liked it actually, because we have been thinking in terms of the differences between the two for the past a few years. And as such, I must confess that right from the beginning of our career as a nephrologist for the past 24 years, 25 years nearly now, and that we have been seeing a lot of type 2 diabetes with the kidney disease, but never bothered much about the type 1 diabetes. And once in a while, we were getting 1 or 2 cases of type 1 diabetes leading to kidney disease. But for the past a decade, we have been seeing a lot of patients with the type 1 diabetes, which have violated the basic principles and also the clinical course descriptions given by the ancestors in nephrology practice, something like a Mogensen. He's not a nephrologist basically, but still for the past 40, 50 years, we have been talking about Mogensen's classification, how the clinical course of type 1 diabetes. And as such, the type 1 diabetes was predominant, and most of the clinical course studies and drug trials, everything discussed much about the role of these drugs in type 1 diabetes. Then for the past 3 decades, slowly after the renal trial and IDNT trial, slowly we started getting more of type 2 diabetes. Now we have a predominantly in our nephrology practice, almost 90% of the diabetic patients with the kidney disease are type 2 diabetic, and 10% of them are type 1 diabetic, but still that number is increasing. And what is happening in the age-wise, if you really look at the age of onset of the disease, and the Mogensen's classification stated that nearly young children who develop type 1 diabetes, for the next 20, 25 years, it will take for them to get into kidney failure. And the type 2 diabetes doesn't follow this kind of a clinical course at all. And the type 1 diabetic patients, they take nearly 15 years to get some proteinuria, 20 years to develop some renal dysfunction, and by almost 20, 25 years, they get into CKD and ESRD. Type 2 diabetics, on the contrary, they come to us with a classical clear-cut case of renal dysfunction, or they come with a proteinuria. Sometimes it can be nephrotic syndrome. And very interesting is that sometimes they come to us with a renal disease. They never happen to have any kind of a kidney diabetes at all. But when we do a kidney biopsy and we see the classical features of diabetic nephropathy, and we find for the first time that they are diabetics also, which was never treated, never diagnosed also. But it's very common that the type 2 diabetes has got no clinical manifestations unless they get into some problem. So that is the one. And here, and the age of onset, we were seeing a lot of youngsters, and also the patients at around 15 to 18 years also with the type 1 diabetes, getting into nearly 3 to 5 years after getting onset of type 1 diabetes, getting into renal disease. This is a gross violation of what has been observed for the past several decades back by Mogensen et al. And now the type 2 diabetes also doesn't follow any clinical course. To start with, they have renal disease, and the progression also very, very rapid. Those patients who are getting a diabetes in 20s and 30s, and immediately within 5 to 7 years, they are getting into kidney disease also. And when we take the patient with the kidney disease, when they take the history, the mean average age of onset of disease and the duration of type 2 diabetes is just 3 to 5 years and not more than that. And moreover, they are very young patients. When we were students, we were taught that more than 45 years or 50 years is the type 2 diabetes. And by the time they get renal failure, they are in 60s and 70s. Now, early onset of disease, and also the early and rapid progression of the disease that has led to the rapid deterioration of the kidney function leading to ESRD very early and fast. So that's the one. The second one, the indication for biopsy. So are we doing kidney biopsy for each and every type 1 and type 2 diabetic? No, we have been doing it actually. I must confess that we have the largest series of patients having kidney biopsies of both type 2 as well as the type 1, almost nearly 2,000 approximately the patients for the past nearly 10 years. And we have a protocol for kidney biopsy, and we found that there's no correlation between the clinical course versus the histopathological evaluation, both the groups. But interesting aspect of this is that those so-called definition, all of us know that is a proteinuria and falling GFR. But a good number of these patients do not have any kind of proteinuria, both type 1 as well as the type 2 diabetic. But the non-proteinuric type 1 diabetic will have a very rapid course, and they come to us with a frank end-stage renal disease within a few months only. Whereas the non-proteinuric type 2 diabetics will have a sustained course, and they stay for a very long time for the conservative treatment, and they maintain renal function fairly well for a long time and before they deteriorate. If they deteriorate fast in a very late stage, it will be very difficult. Previously, once they get into proteinuria, it was said that they never get a remission at all. But it is happening now thanks to the newer therapies, both insulin as well as newer drug therapies, where the proteinuria, especially when it is in the microalbumin stage, that can be reversed back and they can go back to normal albuminuric condition. But it's not, and it can happen even in the lower state of proteinuric conditions also, but not in a nephrotic range of proteinuria, or not in a higher grades of more than 2 grams proteinuria per day. But those with more than 2 grams per day, and usually they deteriorate fast. Patients with a nephrotic syndrome also they deteriorate fast. That shows that the more the proteinuria, more the deterioration, and the faster and quicker deterioration the kidney function. And also interesting aspect in type 1 diabetic is that the patients with the normoalbuminuria are at more risk of coronary artery disease. You know that microalbumin or proteinuria is a surrogate marker of risk of coronary artery disease. But here, without a proteinuria also, these people are getting into more coronary artery disease incidents. And type 2 diabetic patients, they have you know that all of them are at risk of coronary artery disease. Most common cause of mortality in our group of people with the type 1 and type 2 diabetes is the coronary artery disease. That's why right from the beginning, we try to prevent the disease and the clinical course also in them. And another interesting aspect is that non-diabetic renal diseases. When we started doing kidney biopsy, we found that good number of them are not diabetic kidney disease. They are having non-diabetic renal disease. Almost 30 to 40% of them are having a non-diabetic renal disease, something like a membranous nephropathy, IgA nephropathy, FSGS, some of the acute interstitial nephritis, even crescentic. And recently we started seeing some of the very rare entities called fibrillary glomerular nephropathies, which are genetically mediated, and very rare disorders also we started seeing them. That's why the indications for biopsy in a diabetic patients are very, very important. And when we do biopsy, and what we are finding is also equally important. Not only that, some classical indications like a presence of nephrotic range of proteinuria, presence of rapid increase in the amount of proteinuria, presence of recent deterioration in the kidney function, and presence of systemic disorder like a sarcoidosis or amyloidosis suspicion, or having an active urine sediment with a microscopic hematuria, proteinuria, and active urine sediment with RBC cast and etc. You have a classical indication for kidney biopsy. But when we see these kind of indications, when we do a biopsy, we are seeing varieties and varieties of cases which change the clinical course totally. That shows that diabetic patient with a kidney disease doesn't mean that every time it is equal to diabetic kidney disease alone. There can be some other entity that should be evaluated thoroughly, and it can totally change with the treatment a clinical course, which probably change the clinical course of the entire disease. And probably it can become better also if you treat an early and appropriate intervention done properly. So these are the things. And coming to the therapy aspect of it, and therapy is very important, that insulin. And I heard that some of the, from probably you can learn from endocrinologists that some of the patients are getting treatment even for other drug therapies also other than insulin for the type 1 diabetic. The type 2 diabetes, and as my previous speaker, cardiologist, also spoke very well about SGLT2 inhibition. And I'm one of the principal investigators of Credence trial. And we found that it's very important that these kind of drugs should be instituted to the patient very early in the clinical course so that they can get a benefit also for a very, very long time. And non-steroidal mineralocortical receptor antagonist, something like a finerenone, has come into picture. And it is helpful not only in a diabetic, but also in non-diabetic kidney disease also. When we do a biopsy and when we find non-diabetic kidney disease also in a diabetic, we continue with the drug therapy for a long time.
Internet is down for the last several days.
So finerenone is also found to be a very good molecule, and it has made an inroads into the therapeutic armamentarium of type 1 and type 2 diabetes. And finerenone can be given fairly well. It can have function even in type 1 diabetics also. And the studies are going on where these kind of molecules being tried in type 1 diabetes and effect on clinical course. So, and then the complications. The complication wise, the retinopathy, nephropathy, you know that they go hand in hand, concordance rate of more than 90%. Type 1 diabetic patients we found in our practice is that very good number of the patients will get retinopathy and they deteriorate very, very fast, unfortunately. But whereas type 2 diabetic, retinopathy will be stable for a very long time, but they get into coronary artery disease complications as well as the peripheral artery disease complications. So these are the differences which we found in type 1 and type 2 diabetes. And coming to transplantation and dialysis and transplantation, which is very important. And unfortunately, type 1 diabetic patients, they don't sustain well on dialysis. They deteriorate very, very fast. And say, for example, if I have 100 type 1 diabetic patients, almost nearly 80 to 90% of them die in less than 1 year after the initiation of the dialysis. With the type 2 diabetes, they sustain very well, and we can go ahead with the transplantation also for them. And the transplantation, we have done good number of type 2 diabetes, and of our nearly 1,500 transplantations for the past 2.5 decades. And we have around 5 to 7 type 1 diabetic patients undergoing only kidney transplantation without pancreatic transplantation. We don't have a pancreatic transplantation facility in our institute and across. And we have done recently also, for the past 4 years, we have done 4 patients type 1 diabetes with a cadaver renal transplantation. All of them are doing very well, interestingly, at least for the past more than 1 to 2 years of follow-up. They're doing very well. Type 2 diabetics, they get into complications of coronary artery disease. As I repeatedly utter that whatever said and done, these patients are at maximum risk of developing ischemic events and coronary events and strokes, and we should be very, very careful about treating these patients. If at all we plan for transplantation, we see that both the type 1 and type 2 diabetes patients should be screened properly, thoroughly, for occult episodes of coronary artery disease, and aggressive management should be done before transplantation itself, so that they can do very well both on dialysis and transplantation, because longevity depends on the coronary artery disease rather than the management of diabetes alone. As they advance in renal failure, mostly the diabetes gets controlled without any drug therapy also. At least 80% of our patients on dialysis, they do not really require any drug therapy or insulin therapy as such for the control of their diabetes, because by the time they get CKD and ESRD, the diabetes gets controlled automatically. And unfortunately, the glycosylated hemoglobin A1C and other markers are not good markers to predict the changes are probably the control of diabetes in them. So we don't go by any of these molecules, but we gradually follow them up. And over a period of time, we see that they require dialysis and transplantation, and they do well on after transplantation also. We have another entity which is probably not so known to many people outside, is that the post-transplant diabetes, and their management is exclusively done by us and also our endocrinologists locally. And their clinical course also goes very interestingly like type 2 diabetic. They deteriorate. We have few patients who had type 2 transplantation followed by diabetes, and they deteriorated very fast. And they also developed a classical diabetic nephropathy changes in the kidney biopsy. So what we found ultimately over a period of time is that age of onset of type 1 diabetes and type 2 diabetes has changed, and their early manifestations and the clinical course has changed. There's a rapid deterioration despite having newer drug therapies, and we need to see the effect of these two drug therapies like finerenone and SGLT2 inhibition over a period of time. And also, the management involves multi-pronged approach by number of physicians and the surgeons being involved in that, and both the complications can be managed very well if we start very early in the clinical course, if we start them. So thank you, and probably I'm very happy to take up the questions rather than giving an extempore talk like that, because even I don't know what and how much is appropriate to speak now. Thank you.
Yeah, thank you, Dr. Raju, for, I would say, again, a very fluent and wonderful deliberation. I extend my deepest gratitudes to Corner Remedies for inviting all of us. Also, I must say that somebody inadvertently, something we heard about the rains and the virtual and physical meetings. I think in Mumbai, at least, we are literally flooded and sometimes sailing, sometimes walking. Yes, or a cycle.
Sailing and swimming.
Yes.
Sailing and swimming.
Somehow managing. And yes, sir. So let us move on and have some interesting thoughts as from our speakers. And I would maybe like to start with Dr. Raju only, and maybe take the last part of his talk where he was talking about the change in age of onset of diabetes as well as its complications. I would say type 1 diabetes, we have seen it occur more frequently, maybe because concurring with more incidence of autoimmune disorders. But as regards type 2 diabetes, sir, typically we are a decade early. Have you also noted that post-COVID, we are seeing it even come a bit more early? And what is your experience about age at which it occurs and the complications?
For the past few decades, we have been seeing that the age of onset of diabetes and its complications are occurring very early than the one. And I can say that being in a teaching institution and that to continuously at one place, and for the past more than 2 decades, I could notice that I have treated the grandparents, grandfathers, and I've treated the fathers, and also now I'm treating the grandson also now. So the third generation, I started seeing them, and I could really tell them also that you are going to get a diabetes, and their grandchildren have come to me already with the reports, and they are being under treatment also. That shows that the type 2 diabetes, the age of onset has actually preceding and well in advance that early in 20s and 30s, like contrary to the common belief long back when we were students that it's only 40s, 50s and above. And initially we have seen such kind of people also. Even now we have a lot of people who are maintaining very well for the past 20, 30 years. Interesting is that those who maintain well, they maintain very well without any complications. We have patients in 70s and 80s without any single complication. They just like that come. But patients who, young patients are coming very fast and quick with the complications, and especially nephropathy and retinopathy and cardiovascular. So we need to probably address this particular rash issue, because the longevity over a period of time, next 2 to 3 decades, would come down significantly from a mean of 67, 68 to 50s if you don't treat aggressively the type 2 diabetes and the complications. Age has definitely is coming up very early.